We will now start the recording. Welcome, everyone. My name is Evangeline Earthwala. I'm the Alumni Engagement Officer, and today I'm pleased to welcome you all for the last webinar of the 2025 CSE Development in Action webinar series. Today's webinar will focus on From Knowledge to Impact, Building Sustainable Dementia and Home Care Models in Africa. And I'm pleased to welcome our speaker, Ralueke Ekezie, who is a 2020 Commonwealth Distance Learning Scholar from Nigeria. Ralueke completed his Master's in Dementia Studies at University of Stirling. Um, his webinar will address the CSE theme of improving population health systems and capacity. A bit more information or introduction about the speaker. Ralueke is the founder and CEO of Blue Torch Home Care Limited in Nigeria, which is the first registered nurse-led home care agency in Nigeria. He is also the founder and president of the African Nurses and Midwives Network, which is a pan-African platform uniting nurses and midwifery leaders across the various African countries. Of course, during this webinar, he will talk more about his work and within the nursing sector and within the dementia home care workspace. In his webinar and his journey as a Commonwealth scholar, and how he is leading on this work in Nigeria. Ralueke, over to you.
Thank you very much, Eva, and good day, everyone. And thank you for joining this Commonwealth Development in Action webinar. My name is Ralueke Ekezie, just like Eva mentioned, and I am a nurse, a dementia specialist, and a home healthcare entrepreneur, and currently a dementia care coach in the UK. I'm currently the CEO of Blue Touch Home Care Limited, the first registered nurse-led home care agency. And today, I will share a story that is bigger than a personal journey. And it is a story on how learning became leadership and how leadership becomes system change. Specifically, I will be sharing information on how my Commonwealth scholarship delivered through distant learning enabled me to continue making a measurable difference in the healthcare sector while I still study, and how this learning directly shaped the home healthcare and dementia care model we used and built through Blue Touch Home Care Limited. What I hope to that you will take away from this is an inspiration, but not only that, but replicable frameworks that are practical steps for building sustainable and dementia elderly care in low resource settings, and how to strengthen workforce capacity and also community resilience. This aligns with the CSC development theme, improving population health system and capacity. The overview. Today, I will speak on, firstly, I will explain to you how Commonwealth scholarship and distant learning model supported my continuous real-time impact while I was still studying. And secondly, I will explain to you how my work with global research nurses at Oxford University and how it equipped me to train and empower many nurses. I mean, about 2,000 nurses across Africa, and how I was able to establish the Center for Nursing Research in Nigeria. Thirdly, we will go through why dementia matters in Africa and why we must treat it as both health issues and, system issues. Then I will introduce Blue Touch model. I know many persons would want to know how Blue Touch functions and how we are able to do it in low resource settings, the financial model. And finally, I will speak on two sections, which is the practical pathways, how to step by step to build and sustain home care and dementia care, and also the cultural responsive care planning. Because if care is not, if it does not fit the culture, I mean, it will not last. And then we go to the leadership, slide 3, the leadership through the Commonwealth Scholarship. Yeah. So this is the heart of the Development in Action story. I mean, the scholarship supported my MSc in Dementia Studies at University of Stirling, which was delivered through distant learning. Distant learning is a unique way of learning. It's not just a method of study, and I feel it was a strategy for impact. I mean, in many settings, you will understand that when professionals leave their countries to study full time, their local workforces, and what this does is um, it derails whatever development they could do while they were outside their countries or area of functions. But with the distant learning, the opposite happened. It became learning, and the impact ran parallel while I was still studying. As I learned about dementia, its progression and the behavior changes, communication and person-centered, the environment design, the ethics, the safeguarding, the care support, I immediately started to implement the concept in the real situation. I mean, where it matters through my home care work, the training programs where we were able to develop a lot of trainings to impact caregivers and care workers who work under Blue Touch on day-to-day basis, understanding the communication and at least what dementia was all about and how to support persons living with dementia, what to do and what not to do. The training program and advocacy spaces, and also the policy work we did in collaboration with other organizations. And this created a powerful cycle, if I may call it. It helped us to have a learning concept in how we could impact others to learn about dementia in the communities, in the churches, in the religious area, and in the communal areas. How to also apply it in the Nigerian community. I mean, culturally congruent practices and how to evaluate what worked and what didn't work. And also most importantly, is how to improve the models on a daily basis from experiences of what we've done. And we also moved this to teach others on how to replicate. The scholarship strengthened my visibility in many settings. For instance, we understand that in African settings, when you get into a room, they want to know what you have as certificates. And talking about dementia without that certificates really would not have happened, or many persons wouldn't have listened. But with this scholarship, I was able to get into places and I discussed about dementia and people listened even while I was still studying. It gave me the credibility to engage new partners. For instance, people were able to write the Coalition for the Right of Older Persons in Nigeria, who I worked with closely while I was still studying. The research networks we were able to form, nursing bodies, and the community organizations. We do engage a lot of communities and presenting what knowledge we had, the instances we have impacted, they were able to engage us and to speak with authorities, I mean, at both at local and national level. and discuss about dementia and home care system across Africa. I mean, my work wasn't only in Nigeria because we were able to also engage with people in other parts of African continent. Professionally, in a way, um, it helped me to progress into a formal dementia specialist role in the UK as a dementia care coach with one of the biggest care homes here in the UK, where I support dementia units. I also engage in what they call staff trainings. I train staff to know what is obtainable, how to ensure that persons living with dementia has the best quality of life, the best practices and implementation according to policies and the current laws. So that role has also deepened my ability to translate evidence into practice where necessary, which I am at most trying to bring back into the African model of what we are already doing in Nigeria. So when I mention about scholarship to impact, I meant that the scholarship has built competence and created confidence, credibility, helped me to network, and also helped in capacity building for system leadership. And that will take us to the transformational leadership and research capacity. Next slide. So alongside my study while I was still there, I happened to have worked with Oxford University in the UK as African regional lead for the global research nurses under the Global Health Network. So what my work was to help in a major system gap filling up. So many nurses, as we knew as of then, nurses are the backbone of the healthcare delivery sector. But what we realized were that they were excluded mostly in research, or they were non-participants. They were only at the level of data collection and mostly don't even know um, how to use the data. But what we did was to start with skill development and evidence generation. So the research literacy was not only optional in this journey, but without it, you could understand with me that systems wouldn't function. So that is why we implemented research, and through workshops and other programs, the global research nurses believing in me and my exposure already, having a Commonwealth scholarship, we're able to fund research with the research workshops and programs, including radio programs and collaborations we did to help us, including through African Nurses and Midwives Network, to empower about 2,000 nurses in research scale and clinical capacity building. The picture there is one of the cross-section picture we took while we had one workshop in one of the states. I think that was in Enugu. Um, a key output to this work was establishing the Center for Nursing Research. So, having seen the gap, and while I was having my scholarship and working with University Oxford, uh, I made a move to bring this home as well. Having seen the impact of research as a Commonwealth scholar, try to apply to the establish this. A lot of drawbacks anyway, but I was able to use the networking skills I had, which I also developed during the um, scholarship process to get what we call a letter of no objection from Federal Ministry of Health. to currently establish the Center for Nursing Research. While we did that, was that it's designed to help nurses to understand research languages and ethics. And also, like I mentioned earlier, research is the backbone of every health sector. Engage with evidence-based practice, which is the current thing, and participate in data collection and implement quality improvement. Also, that will help to translate research into better patient outcome. So workforce capability is not just number, but capacity building as well. Because we believe that when nurses and other persons who work in the healthcare field can think critically and also are able to interpret evidence, and evaluate outcomes, the health system becomes much, much stronger and functions more effectively. That will take us to also speak on the slides where we are able to practically, we're not hearing about research as of that time, and we are learning how to frame clinical questions and also how to document outcomes of what we have learned. This matters because while I mention here, is because we cannot, talk about dementia care and elderly care because they require consistent documentation and monitoring and also learning. When people are trained in research thinking and quality of long-term care arises, there must be always need for clinical research to come in. And then that takes us from knowledge to impact, the practical pathway. So in this slide, what I did there, if you look at it from the very first column, I had to highlight all the input of what the scholarship had done, which includes, getting the Commonwealth Scholarship in the first place, and what my MSc learning, and the global networks we were able to form. Also, the exposure to evidence-based dementia care. The column 2 described the competencies I gained through this scholarship inputs. So here, the scholarship, what it did was to enable dementia knowledge to flow as required, which is lacking in Africa, even up until now. Create a leadership skills, communication skills, also helped in behavior support, how to support residents and people living with dementia that are showing behaviors of concern, and also research literacy and system thinking. So what the column 3 is showing is the actions, what this has helped us to do, establishing Blue Touch working pathways and improving what we are already doing before now. We were able to also train dementia champions across communities who are the one that carries the knowledge from one point to another and engage communities in de-escalating different challenges with persons living with dementia. And also, we're able to conduct research workshops, ability to also network and get the fund. And we're able to establish the Center for Nursing Research for continuous learning and impact. We have also piloted and currently working on a telehealth care setup, which we will discuss much more in the slide down there, how this telenursing works. And also, we worked on policy engagement, working with other sister organizations who opened their doors for us to discuss on how to promote elderly care and other policies formed that is being promoted to be or championed in the chambers for approval. How did this impact the population health, the outcome level? So this, what it did was to improve caregivers' competence and reduced crisis admission because we know that majority of persons living with dementia in Africa end up not being diagnosed early, and this leads to uh, crisis admissions and also late stage diagnosis, which impact their life in a negative way. It improved caregivers' competency because they are able to learn practical ways to support persons living with dementia. Also, workforce capacity building through training and improve dementia awareness. We were able to create models we used to train people to understand when early diagnosis and early signs are seen, and stronger policy attention to the aging through advocacies. In, so this table is important. Why? Is because it shows that scholarship impact is not only for personal achievement, as far as myself is concerned, but it also could be a way we could influence a system architecture. They take on the dementia in Africa and why this works. Next slide. So you could see the statistics. If you go down the right side, down there, you could see the impact of dementia in Africa at the moment, what it could be in the next, by 2050. And it means that Africa is actually aging. I mean, the older populations expected to rise dramatically, and from 74 million in 2020 of older persons, it's expected that they might get to roughly around 235 million by 2050. And what this means is that it's predicted to, um, it may exceed 10 million cases by 2050. That is people living with dementia. And but the statistics is practically frightening, if you may know, because 85% of persons living with dementia in Africa don't actually get diagnosed. They don't have diagnosis. And most families also, they don't want to um, say or I mean admit that someone is living with dementia and there is no structured dementia support in Africa, and except what we're able to do at the moment. And then what this means is that the health condition in Africa, as far as persons living with dementia is concerned, it's not just if you look at it from a professional point of view and politically as well. It's not just an equity issue. I mean, it's an equity issue, and but not just that. It's also a workforce issue because there is less persons delivering quality dementia care in the healthcare sector. And it's also an economic issue because there is recently no budget for persons living with dementia in many Africa countries. And also it's a gender issue as well because majority of the primary carers and are women, and this derails their work and engagement in other sectors. And it's a system issue because the system is currently not supporting it. So the question we may ask is, how do we build a care model that works and work formally without system limitation? but this is what exactly Blue Touch does since over 10 years now. And that will, if you look at the data down there, you could see it stratified as both what is in sub-Saharan Africa and also other parts of Africa. But generally, Africa is rising from 4 point something million to almost 17 point something million in 2050. And the question remains, who will be the one to actually give this care if we are prepared for that? Next slide, please. So what is the Blue Touch model? What Blue Touch is doing is quite significant to the growth of persons working in the healthcare sector regarding dementia, and also trying to equip persons and the families of persons living with dementia with knowledge in different areas. So Blue Touch were able to where we saw a gap where families are being overburdened or with care of their persons living with dementia. So what we did was we were able to register as the first nurse-led one in Nigeria. And also hospitals could not be able to provide long-term care for people living with dementia. And there were limited home care standards because the system has not actually seen it as a burden. But when we registered, we have been able to serve a lot of clients while also training a lot of hundreds of nurses and caregivers who now are capable of identifying the early signs of dementia, also able to counsel family members and support them through the journey. But what made the model different is that it was built using the blend of nursing professionalism and system design. From what I learned from the scholarship, we were also able to work around different ways of care by giving caregivers education and community integration. For instance, going into a community and understanding what the culture is around there. We'll still talk about the culture aspect of this and trying to work around with them to also have community champions on dementia care. And we also have developed what we call dementia specific pathways informed by my MSc learning. And we currently also developed what we call Dementia Cafe, still in the baby stage, but working out very well as we expect it to. What this has led is we've come to be recognized in some awards where we were recognized with the Impact Africa Healthcare Provider Excellence Award in 2022 and Connecting Nurses Care Challenge Innovation Award 2012. Um, is these are one of the two of the most significant ones. We have also been involved in many other awards. And now the critical element here is that we did not build a clinic, but what we did was to build a model. And you would understand with me that models can travel and also be replicable, and model can scale. That takes us to components of sustainable dementia care. Oh yeah. So we're already there. So our dementia care has about 4 or 5 components. So what we did is championing the dementia uh, care by training what we call dementia champions. So we trained caregivers and not just nurses, which we also trained family caregivers, the primary carers, and care assistants in the homes. And um, the dementia champions, their job were is primarily to act as the community level support capacity. So they go into the communities to have a chat and carry out what we call needs assessment. This assessment, we are able to also understand what the community is about, what the individual, seeing the whole individual and not just the diagnosis, being able to also use the terms that is acceptable in the communities. Then the second stage of it is the community dementia awareness program, because we all know here that there is still stigma attached to dementia, which is a major barrier in care. And we engage communities through their churches, mosques, and town union and or union leaders like women groups, men groups, and this promotes early understanding. For people to know what dementia is, you need to embrace what their culture is, what the community wants, what they really know, and what they don't know. So know where to start to engage them. And this were what we did. You'll know that in where the church leader speaks in Africa, people listens, or where traditionalists who believe in them speaks, people listens. So this is the second stage of what we did. And then there is the cultural adaptive memory and behavior support planning, where we, instead of just using everything we have learned from uh, the Western countries or what's already existing in the Western world. Instead of putting all of them, what we did were we tried to integrate the African way of life, the routines, and the identity-based care, because family roles are very important in dementia care. We also have to bring in whatever the individual's religious rituals are, their titles, the family foods, storytelling, and music therapy. That's also where you could bring in your dementia cafe if that is one of the ways to do it. So what dementia cafe entails is where people come together to bring their elderly ones, older persons, and persons living with dementia. They interact with themselves. This is kind of creating a community of persons having the same needs. And what this does is it encourages people to speak up. It encourages people to understand what dementia is and reduces stigma. So then there is telenursing service for underserved communities. So here we have developed, uh, still developing, not yet functional, a low-cost model of care where rather than us using the internet, which is what is in vogue at the moment, we have tried to develop a model where people can actually call with normal phone, and they will be charged by their airtime. And with our system and human manned tele healthcare call center, we're able to quickly advise them, advise caregivers on what needs to be done, and also in terms of crisis guidance, what needs to be done during crisis event and how to de-escalate, but most importantly for quick intervention. So these four components we just discussed here is what allows dementia care to exist beyond the four walls or be institutionalized of the hospital, and also help to reach the underserved areas and how hard to reach areas. So that would take us to the practical pathways for sustainable dementia care. So this section, many people ask what are the practical steps on how to do it. But for us, we call it pathways because each one of them is repeatable route from need to, making an impact in a community. And the first pathway we use is community dementia awareness framework, what we call it. So the goal is to shift from the stigma to understanding of what this is. So we try to engage the faith spaces. First of all, to discuss with those who are the leaders, the local groups, to, in simple terms, explain what is going on in the brain when dementia is starting, explain the activities they see the person living with dementia exhibit, the memory loss, the behavioral changes that is to be expected early on, and the confusion. We know that in the contemporary African setting, they still think that dementia is about spiritual causes. So, but when we engage at this stage, we don't bring in or blame spiritual causes. We encourage families to seek support early rather than rather than isolate the older person. So, and then we have how we do the assessment, what we call the home-based assessment pathways. So the goal here is to assess the individual, and instead of relying in a facility-based assessment, our nurses tend to observe the daily routine of this individual, how they function, how they eat, or how they are assisted with eating, and also try to look at the safety risks in their environment, the communication pattern, the sleep pattern, what triggers the difficult behaviors they exhibit. And also we try to assess the home environment, the lightenings. How is the home lightened? Is the pathway quite well lit at night? And then is it free of clutters? What is this home about? Do we need remodernizing it or changing the environment, the setting? And then fall hazards, we look at that. And working with purpose, I mean, what some of us may call wandering, we call it working with purpose, because this language really matters when we speak it. And we try to look at low cost modification because we know that it's also financially, there is financial implication. Low cost modification could be if you are living upstairs, could you move downstairs? We could put a rail along the the walls for someone living with dementia to we could use cues like labeling the toilet, which we rarely see in the homes. These are how you make a home dementia friendly: labeling the toilets, labeling the room doors, labeling whatever it's available in a clear format that the person could be able, someone living with dementia could be able to relate with. And then there is simple diagnostic forms that we could use that are currently used in other areas or countries of the world. We have the one we call mini cog. This is just a simple clock drawing or three-letter words. And then we have diadem and CCITs. These are things we can easily adapt to what we are doing. So we could be able to dictate the dementia quite early in older persons and also not persons that are showing signs of cognitive decline. Then we have the third pathway is the family engagement protocol. And the goal here is to share the caregiving with the family and reduce burnout. Oftentimes, most family members get burnout from care of persons living with dementia. And a practical example to this could be holding a family meeting with persons you've identified as living with dementia. What we often see is we go to families, they've called, invited us for assessment, and after assessment, you try to inform them that your parent or loved one is living with dementia, but they refute that um, because they don't know what it is at the moment. So we try to share this caregiving. We could tell them, okay, we will engage with your parent and we will come in to try and assist you to introduce this test to them. And with that shared structured meetings and etc., they tend to establish trust, which is very important in this process. And we are able to identify the primary caregivers in the family roles and the education we do and educate them and have these decisions made. We try to also, at this stage, you try to clarify the needs. What is real? What is just the belief, and what are the just the cultural thing? Or yeah, and then we start to assign responsibilities to each person. What our caregivers need to do and what the family caregiver or primary carer needs to be doing. And then try to teach them, the persons, how to communicate with strategies, such as calm tone and also short sentences. Try to establish ways of engagement and uh, build what we call familiar routine because in dementia, brain can relearn actually. And then this also helps to understand the progress of dementia, how it's progressing. And we try to um, inform the family members when to seek help from a home care support team or from where they can get help, possibly as practically as possible, because there is a time when you have to educate them to understand the families that there is a time where you now need professionals to do what you are doing rather than continuing in the home. Then the final pathway we use is telenursing support and remote follow-up, which I discussed earlier. The goal of this is to scale and also continuity of care. For instance, we try to establish a way of communication via telephone And what we are doing is this is going to be an application also that will be equipped with few certain things, including familiar um, music and etc. So, for instance, if your caregiver is there and is having a crisis they could not manage, they would be able to ring and speak with a team member, or we give a recorded um, program they can use to de-escalate the situation and restore the emergency situation. Also, this telehealth project we are doing is also aimed to improve sleep disturbances. So family don't resort to medications or hospital emergencies. And why this is very important is that it reduces the number of admissions we have and reduces caregiver stress. And the person with dementia also experiences have a better dignity of life, and the health system burden is also reduced. And then we go to the practical pathways for sustainable home care. So if you look at those columns as well, we have the challenges that is there. And the first column highlights the real world challenges for families and health systems, what they face while dealing with dementia in Africa. The first challenge is low awareness. Families do not really recognize dementia as a health condition, and the early signs are vague for them, such as the confusion, the behavioral changes. They don't know about this, what they don't understand it. So it's entirely very difficult and misunderstood. And closely to that is the stigma that follows. In some communities, dementia is associated with witchcrafts, especially in some African setups, so which requires spiritual punishments or moral failures. And the stigma, in a way, it causes families to hide or not to, stops them not to seek help or hide the person who is affected or the relative. And this delays the diagnosis and identification of persons living with dementia, and it avoid community, stops community support from coming. Another challenge is the limited access to specialist services. Um, at the moment, there is no existing memory clinic in many African countries. Many, there is, I mean, 85% of them don't have memory clinics where you can actually diagnose and implement care. And there is less specialists in dementia, but thanks to the scholarship, I mean, we are increasing in number gradually. Um, and also in many cities as well, you may see few works going on, but the communities and the rural areas, which harbors most of the population, still are quite finding it very difficult to have established pattern or structure of dementia care. And then we have the rural exclusion. But the interventions there is the community engagement awareness programs, like I mentioned earlier, where we try to build communities capacity at that level and introduce the dementia champion trainings, and also try to identify early signs. And then through Blue Touch, we're able to, with the knowledge we have gathered recently, develop home visits, provide home visits, which helps us to assess the person living with dementia in their own environment, using their daily routine. And then family coaching. to coach the family on behavior management, like we mentioned before. What are the tools we could use? Like I mentioned before, um, the simple screening tools, CCIT, diadem, and Minicog. Then we develop a care template which helps to standardize support. I mean, the care template includes the daily routine of the individuals, the behavior triggers, communication tips, safety measures. I mean, what the families can follow at home in the absence of a, a specialist care personnel. The home could be able to also use this care template to do as much as they can. And then we have the telenursing checklist, um, a guide that should be used for remote support. I mean, when a caregiver calls for help, what is the nurse or the person receiving the care going to do? The checklist is how to assess the situation and give credible advice. Informed advice and decide whether escalation is needed or not. And then create a referral pathway. The referral pathway works like what we call referral partnership. So we have to engage with hospitals and other care providers that would accept clients at any time of the day where there is need for referral. And this uh, team are being contacted once we need to refer. So that creates an easy referral process. If you've worked in the African settings, you would understand that referrals sometimes, or people who go to hospitals, tend not to access care immediately. But when there is clear referral pathway, families know where to go and who to contact, and also it prevents unnecessary crisis issues within the process. Then the outcomes, what this has done is that uh, there is early help seeking. The families tend to recognize the early symptoms and signs as soon as possible and seek guidance. And what other thing it's done is there is an improved caregiver competence and confidence while they support persons living with dementia via informed knowledge, and they feel less overwhelmed with the training they've received. And thirdly, we observed reduced crisis and emergency hospital visits because the thing is that with well-equipped community and families, as well as caregivers, many behaviors could actually be managed at home with appropriate guidance. And finally, the improvement of quality of life, which is the beacon of dementia care. And both the person living with dementia, the carers, and also the family members, the primary carers, because this makes things to become more predictable and less frightening. So improving the quality of life of person living with dementia and their primary carers is very important. Um, and then why culture matters so deeply in dementia care. You know that in many African settings and contexts, some illnesses are actually linked to religion and is looked from many lenses. It might be medical or spiritual and or social one. So what we do is to ensure that what we do is to ensure that moral and social obligations are met, and often deeply held beliefs are worked on across this fair before we engage a community. Um, when you work, while we work with the cultural frameworks and gently then introduce the medical aspect of it. So this is a practical way we did this. And the first principle of the cultural care is alignment. We try to align things with the view of the families and the communities, but not confrontation. And this has helped a lot in trying to not directly contradicting the family beliefs if they reject the care. So practical ways as well could include using the old folklores, storytellings, and other method, local proverbs, prayers, routines, the family photographs to ensure that the person living with dementia is having a quality of life that is important. So how Blue Touch integrates this role?
Ralueke, do you want me to go to the next slide? Do let me know.
Okay,
Is
yeah,
it this slide or the next one?
that's cultural responsive care. Yeah, this one is fine.
Okay. Also, just a short announcement. I know we're running a bit over time. So for the audience, um, m- please do remain online if you have availability. But if not, and if you need to, if you have other commitments, thank you so much for joining. The webinar is being recorded, so we will make the recording available on CSE's YouTube channel. Thanks, Raluki. Over to you again.
Okay, go to leadership, entrepreneurship, and system strengthening.
Yes, it's this one.
Yeah.
Thank you.
So now let's talk on sustainability. So because the impacts, we cannot sustain it. If we can't sustain impact, what happens is that the project dies. So, and the care cannot be sustained just with charity alone. So what we did is the Blue Touch model was built as a social enterprise model. And what this means is we pursue social impact first, but we also use business model to sustain service delivery. So we currently work with communities, carrying out needs assessments and gather data to inform our PPP proposal with various organizations and other parastatals, including government at state, local, and federal level. In simple terms, we try to we are not a profit maximizing company because we believe in the game of number and we are not a donor dependent NGO as well. We sit in the middle, trying to combine the compassion with structure and try to also ensure our purpose of planning. So, why this model works is because dementia is a long-term condition. So, what we do here is to bring in the um, people who could pay their bring in their fund and then try to subsidize for those who cannot pay. That is the way we could be able to sustain care for both the elites and those who cannot afford it in a simple term. So what this social enterprise does is that it ensures the continuity of care and predict service availability and also help us to have a stable workforce and ability to plan. Another thing we've done in Blue Touch is what we call tired pricing. we try to use a price that is basic, but could reduce it for those who might not be able to afford it. Once we can cover the cost of care for the for the caregiver that is doing the job at that moment. And then we reinvest this into the care. So So we could use the partnership to scale and collaborate to avoid duplication. And networks we use accelerates care, helps us to ensure that many number of persons needing care are covered. We can go to impact pathway. So a major part of this impact is policy engagement. Early on 2022, we started with, I engaged with Coalition for the Right of Older Persons, which I got involved for us to contribute in advocacy work. And we tried to, where I was involved when I was the state coordinator in Enugu State for us to draft the Older Persons Bill, which has been taken up long since by the Center for Older Persons in Nigeria and is currently at the Senate House debating on passing the bills, which will include care for the older persons, reduced tax, and also other many benefits the older persons could. This also includes people living with dementia. And then I was able to also use the African Nurses and Midwives Network to engage and was a board member at International Home Care Nursing Organization through my networking. This all helped to shape the knowledge that we've gathered and leveraged the collaboration. So and the network helped to create an ecosystem where dementia care is kind of not only isolated by ourselves, but it's also helped to connect to practice and the research community action policy. Let's go to improving population health. So the overall population health value, what we use is our model, which is adaptable to low resource settings. So through the training pipelines, what we did was to strengthen capacity for dementia specialists and home care nurses and also caregivers. And through African Nurses and Midwives Network and also related organizations, we are planning and also working on using it to extend in about 20 African countries to deliver capacity. And the community care also to integrate the helps would, help to reduce pressure on the hospitals and improve quality of life and strengthen health system at the household level. The next one should be the pictures. Yeah, so this picture is from the left side is where I met uh, from the left side up is where I met Miss Kathleen, Professor Kathleen, where when I visited the king, when I got the invitation, you could see the invitation at the topmost right um, in 2023, I think. So I met Professor Kathleen, who was then the president of Commonwealth Nurses and Midwives Federation. And we received the King's Handshake. This is down at the left is where Blue Touch received an award of recognition from the Northern Arewa Northern Student Association. And at the middle is where we received the African Impact Award 2022 uh, for the best healthcare provider in Africa, I mean, in home care settings. And the down there is the award we received from the Connecting Nurses Care Challenge Innovation Award in 2012 for working in the healthcare sector to deliver um, sustainable care. So the next slide would be the question and answer. Um,
Yes,
so
thank you so much. I'll let you take a few moments. That was a brilliant presentation. If you do get a chance to have a look at the chat box, please do scroll through the chat box. Some really good positive feedback coming through for your presentation. And the audience are really appreciating how you have gained so much from your scholarship experience, being a distance learning scholar, and implementing your learning through your work in dementia care. We do have a few, I can see a few clapping reactions as well. I hope you can see that too. We do have a few questions that we have received in advance via the registration form. So if you have sent in questions, thank you so much. We will try to raise a few from there, but I'm also planning to raise a few questions that have come through in the chat box. I will be taking time from the post-webinar networking session because I do want everyone to have this opportunity to listen to the questions that have come through and for Ralueke to address these questions. Uh, so if you are ready, Ralu, are you ready for the first question?
yes.
Perfect, thank you. Um, so the first question is, how can simple, affordable technologies be used to improve home care and safety for dementia patients?
Okay. In simple terms, it's like I mentioned in the presentation, you would understand that there are ways you could use telehealth. Obviously, I'm not the fan of the current telehealth that because the African sector, our internet is still very
Yep.
slow,
Hmm.
and 75% of persons living in Africa are still in the rural areas. So what we are encouraging is to build low cost, internet free or at least hybrid um, uh, stuff, telecare that you could use to give advice to families, give advice to your care staff if they are doing home care and
Mm,
live-in, and also general publics who could call from time to time to um, really want to know what they could do at a particular moment. This could evolve in the future when the internet has improved more. But at this stage, the internet still is a very big barrier. But things are coming. There are also AIs out there that people are proposing that are coming in, from time to time. But I believe that we could start from ground zero to build up.
perfect. Peter, I will come back to you after the next question. Um, Many countries in Africa still practice communal lifestyle. How are you prepared to challenge it? Is there a specific research done in Eastern African countries, and how are you connecting all stakeholders in Africa to address this?
Um, Rural setting is rural setting everywhere across the world. The first thing to study should be the way of life, like we mentioned in the presentation.
Mm-hmm.
You need to get close to the community, use probably the community dementia champions who could go in there, establish relationship, understand what is ongoing, understand their way of life, and plan a culturally congruent practice that they could be that could be implemented in that area. Working with that is what we call community engagement protocol, which I mentioned there. You could use that to engage a community and have a quite easy and seamless plan, which they could also be involved. People even with dementia can be involved in being an advocate in
Mm,
that rural community when you are able to equip them with the required knowledge.
perfect. Peter, I'm going to go next to you. Uh, but if there are any other questions from the audience, please may I request you to send them in the chat box. Peter, over to you.
Thank you very much, Ivan. Thank you very much for your presentation. So, my quick question is: you mentioned the thing about religious beliefs and family beliefs and how you try to handle that. I can understand how deep-seated it can be. So, where do you draw the line, especially when religious beliefs and family beliefs clearly are in opposition to proven scientific approaches to improve their health outcome? Thank you.
Is this the health outcome you mean? Is this regarding dementia generally or general health?
Yes, particularly to
Dementia.
dementia. Yeah.
Okay, so the thing is, religion, as we may know, is a belief that people practice. And if you want to tackle religion, it's best to tackle it from the head. The our people in Africa, in many parts of the world, listen to who they follow religiously. If the family directly are not understanding what you are meaning, you could go through the leaders. But again, you remember what we call Bill of Rights. um, an individual and ethically, an individual living with dementia and the family, if they hold the power of attorney, though I don't know if this is currently existing in African settings, but if they hold this power of attorney, they can make the choices. And when they make the choices, according to Mental Health Capacity Act, you have to respect what their choices are. However, if we are talking about the settings where you think the only reason or barrier is the knowledge gap or understanding, here there are many ways to go about it. You try to engage the family, and if the family itself is not able to budge, then you could move to religion. If you know, or community leaders, there are many channels. But when you have explore all these channels and they are not working, then you have to then try to refer to probably the most professional involved. If there are no risks to themselves and risks to the families. If it's over in the Western world, there is what we call safeguarding. You raise safeguarding, and then through safeguarding, the government will take it over and manage it. But down in Africa and some other parts of the world, these things are not existing. So we will have to respect their decision when you have explored all options available to you. Or you could also use pairs. There is, like when I mentioned Dementia Cafe, you could invite the person to one of your sessions. Just come and sit in and listen to us, you know. I'm not saying, a family member can come in and sit in and listen to us. And when they come, maybe one or two things they learn might make them change their mind.
That's a really good point, Ralueke. And there have been comments in the chat box as well about um, about having a parent suffering from dementia, and how useful this webinar has been for them. Um, the next question is, what has been the most challenging part of your model of dementia care?
There are many challenges, many challenges. Um, but one that stands out is funds, which I don't call it funds, but universal health insurance,
Mm,
which is not available. I would say this is the most difficult one because you have to then go into what we call the social enterprise model and seek for people to assist with funding. And then if you go to our website, Blue Touch Home Care, you will see where we say elderly support care project. Donate 1,000 or five or whatever you can. So for someone who is living with dementia to or older person to access care. Now, because there is no insurance, that will throw you into seeking for other means to ensure you do what you love doing. So I see this as the major challenge. There are other challenges, but I believe those ones, if we have, I mean, many persons shy away from care because they feel the money will be involved. If they see and you say, oh, this is free, we've seen it. People saying, I don't need the care. But when you say, oh, this is free, someone has paid for it, they're okay, come and try. And from that trial, they start seeing the changes and less burden in care of the person living with dementia, for the family, for the caregiver, and for the person living with dementia, him or herself. And they are open now for, doing more. So that is the major challenge, but you have the you have the answer to that.
mm,
Try to use your social enterprise model. It
yeah,
works.
yeah. Thank you. Moving on to the next question. Do you see a future for an institutionalized adult social care in Africa, Nigeria in particular, similar to what exists in the UK, for instance?
Exactly. I will tell you, for example, after my nursing school, I started Blue Touch immediately, just 2 years or so after, but I've registered, but started officially. And when I did, none was existing. And people didn't believe. My peers asked me to go and find a job in the government sector as a bedside nurse. But in fact, I didn't know that there is something called home care other places in the world. I just thought I don't want to work in the hospital. I need to start something new. And then today, people have taken the inspiration, and I think we have about, if not up to 10 home cares operating in Nigeria. So definitely there is future for everything, but one person must have to take the step to show others that it is practicable, and they will definitely join up to do something. And with time, they will start to, you know, engage others, and you will start to get close to the government. So that's how it works. There is future for everything in any country.
Great. Just looking at the next few questions in the chat box. You mentioned that a significant proportion of patients, particularly in Africa, remain undiagnosed. Could you please elaborate on the way forward to address this challenge?
Yeah, I mean, it's the first way forward is to engage collaboration. I believe in the power of collaboration. Oftentimes, the difficulty we have in in Africa is not presence of knowledge, but lack of collaboration. So, like currently, I have the knowledge, and in my during my MSc time, I think I have 2 or 3 more Africans, and then I have people who joined in before we just graduated who are from Africa. We can come together and decide to, and now I work in the sector in the UK, pivot to a lot of um, information and how we could create our own simple diagnostic and memory clinics where people can walk in and just with a paper, it's simple. With a paper, you could ask few questions, and these people living with dementia get diagnosed early. And then we take it up from there. So I think that's the way forward. Collaboration. I bring the knowledge, you could bring the human resources, and the other person could bring the house where we use as an office. And then it's the way forward. We start to do it. It's as simple as that. We create our own way. We create ways to do this. And oftentimes, you may know that when governments see results, they want to partner. If they don't see results, they find it difficult to really do anything with you.
Definitely. And you're talking about partnerships, and this is also for anyone in the audience, or anyone who will see the recording later, watch the recording later. If you would like to get in touch with Ralueke and learn more about dementia care, whether you're in Nigeria or elsewhere, if you would like to learn more about partnerships or would like to collaborate with him, please do get in touch with him. I will share his contact details very soon in the chat box, and it will also be shown on the screen. Perhaps the last question, I'll just see how it goes with time. Um, did you get a chance to adapt the WHO integrated care for older people? The handbook or the guideline it is, considering that one of the 13 suggested care pathways is how to assess and manage cognitive deadline. Um, is the screening done by your dementia care facility or referred from other PHC facilities?
Um, I see that question was
Yes,
asked by
by
Joshua.
Joshua. Yes.
Yeah, so the ICOPE is a very important tool. And what we do is we work based on the resource available. Like I mentioned earlier, we are working in trying to adapt what is in ICOP and also matching it with what is in we see practical in the communities and in the life in life settings where we work. Yes, we are trying to input that into our daily work because one of the other work WHO has done was also the community friendly develop dementia community friendly concepts they publish at a time, which we are also trying to do. However, we are only at the care level and not community, I mean, making community dementia friendly at the moment because it's a quite different challenge in Africa to do the community friendly environment. But we are implementing it in the homes, like I mentioned in the presentation. You can do simple, easy modification
Yeah.
in people's homes, like making the steps flat and etc. So yeah, we are using that to implement things.
Wonderful. Well, I think with that, we've come to an end of the Q&A session as well as the webinar. Thank you so much for responding to all the questions. Well, most of it, I hope I haven't missed any questions, but if I have, please feel free to connect with Ralueke. I have shared his email address and LinkedIn in the chat box, but you can also see it here on the screen. Uh, Please feel free to get in touch with him if you have any questions or would like to collaborate or connect with him and learn more about his work in dementia care. Uh, Ralueke, before we end, any final words?
Um, I must apologize for keeping you longer than
No worries.
expected.
Don't worry
And
about it.
I appreciate that persons join, and I really appreciate the engagement. It means that this is an area of interest for many persons in Africa. And I saw a question asked by Dr. Cornelia Ndifun.
Oh, yeah.
I I started up from Enugu actually. Yeah, my very first home care office was in Enugu, and I would like to engage with yourself if you could connect with me. Um, and yeah, it's really a very wonderful experience to be with you all. And I visit my country, I visit Nigeria like twice or three times every year. I could plan to have a meeting anytime, any day. So I'm available. Thank you very much.